So good evening, everybody. We are live now, sir. We can go ahead.
Good evening, everybody. It's indeed a great pleasure for me to welcome all of you for this lovely debate which you are going to have today. It's the debate on the total hip replacement, what approach to use, the direct anterior versus posterior approach. And we've been using the posterior approach for ages, but of course the direct anterior approach has come in the last, I would say, 5 to 8 years, and it's rapidly gaining popularity. And today, to debate this topic in total hip replacement, which is better, the posterior approach or the direct anterior approach, we have two stalwarts who are really going to take us through the advantages of each and tell us why which one is better. So to speak for the posterior approach, we have Dr. Harish Bende, who's from Mumbai, and he's trained at the HSS in New York, and he's going to tell us why posterior approach is the better one. And then, of course, we have Professor Jay Parvezi from the Rothmans Hospital in Philadelphia and the Jefferson University to tell us why shouldn't we do the posterior approach. And then we have Jose Rodriguez, who's actually doing both. I have seen him do the posterior approach, and recently when I was at the HSS, I was surprised to see that he also does the anterior approach. So he's going to give us a balanced view in the end. So with this small introduction, I want to welcome all the panelists, Dr. Rajiv Joshi, along with Sahil Sanghvi and our patron, Dr. K. Sancheti, and also the two stalwart speakers, Jay Parvezi, Harish Bende, and Jose Rodriguez, who's going to moderate. So before I say anything further, I want to hand over to today's coordinator, and who's the joint replacement surgeon at Sancheti Hospital, Dr. Sahil Sanghvi, to take over the further proceedings. Over to you, Sahil.
Thank you, sir. So I'll just share my screen. And is my screen visible?
Yes.
Yes.
So I welcome you all for our first debate on the hip arthroplasty dilemma series, which is anterior versus posterior approach for total hip arthroplasty. So speaking for the anterior approach, we have Dr. Jawad Parvezi. He is the co-founder of the International Consensus Group on Orthopaedic Infections, and he's been the past president of the Musculoskeletal Infection Society. He's a renowned world expert in prosthetic joint infections. He has more than 800 peer-reviewed scientific articles, 30 textbooks, and 200 book chapters, and about 60,000 citations. He has more than 50 awards and honors, such as the Chitranjan Ranawat Award, the Mark Coventry Award, Insal Award, the Best Researcher of the Year Award, and the Otto Frank Award. Dr. Jawad Parvezi, we welcome you for this webinar. Speaking for the posterior approach, we have Dr. Harish Bende from Mumbai. He has completed his MCH Ortho from the University of Liverpool. Thereafter, he did his fellowship in joint replacement at the Lenox Hill Hospital in New York with none other than Dr. Chitranjan Ranawat. He has a vast professional experience of about 30 years exclusively in the field of arthroplasty and has trained in the United States, in the United Kingdom, and Germany. He has been the past president of the Indian Arthroplasty Association and is a founder member of the Indian Society of Hip and Knee Surgeons. Dr. Harish Bende, we welcome you to this webinar. Dr. Jose Rodriguez, our moderator for today's webinar, was the Chief of Adult Reconstruction and Director of the Fellowship in Minimally Invasive and Complex Hip and Knee Surgery at Lenox Hill Hospital. He is now practicing at the Hospital for Special Surgery in New York and has won multiple awards, such as the James Rand Award for Outstanding Paper in Knee Surgery, the Maurice Cowan Award for Excellence in Medical Education, and the Chitranjan Ranawat Mentorship Award. In addition to his vast experience, he also serves on the editorial boards of the Journal of Arthroplasty, the Bone and Joint Journal, the Clinical Orthopaedics and Related Research Journal, and the Hospital for Special Surgery Journal. Dr. Jose Rodriguez, we welcome you to our webinar. Our panelists for today are Dr. Rajiv Joshi from Pune and Dr. Hemant Shirali from Canada. And we'd also like to welcome our patrons, Dr. K.H. Sancheti and Dr. Parag Sancheti. So I'll stop sharing my screen now, and I'll hand it over to Dr. Jose Rodriguez to start the proceedings.
Well, good morning. What a delight it is to share this time with all of you. I am honored and truly delighted. As always, these are my disclosures. It's important to know. So it's a great pleasure to moderate between these two thinkers, surgical artists and gentlemen, both of which have been thinking intensely about soft tissue management and beauty in surgery for many years. Harish and I spent our formative years together many years ago. And Jay might not remember, but I think it was 2009 when I was just starting with anterior approach. And I said, Jay, you should consider this. And he said, no. And I said, you should consider this. And wow, has he considered this? Awesome. Now, approach it's kind of like religion. You know, this is how we learn a way, and then we're stuck that way. And I've had the honor to visit the institutions founded by Charlie Mueller, HSS, and Jose and Letournel, and learn from their disciples. And, you know, beautiful surgery is beautiful no matter how or where it's done. But in the end, an approach is a path. It's a means to an end. And the end is a supremely functional hip. We must understand and acknowledge that not every execution of an approach is the same. We all have our individual learning curves of execution. Some are narrow, some are broad, and we have to be honest about that. Also, there is no free lunch. Every good has a bad. And finally, approaches and the common understanding of execution of approaches continue to evolve, and these are beautiful things. A hip surgeon should understand all approaches to the hip, but you have to choose one for every day. These are images of Dr. Anwat demonstrating hip surgery, which should be beautiful. It should seem easy, right? Just like a great athlete makes a movement seem easy. And it's just following a specific technique to achieve that movement. The principles of arthroplasty are the same regardless of approach. The anatomy is the same. It's just the other side of it. It's the execution that's different. Here's an example of me demonstrating the technique that Dr. Anwat taught us of testing the anterior capsule to assure that there is sufficient tension so that there is no anterior dislocation. And in the 12 years that we spent working very closely together, after he had adopted this technique, Dr. Anwat did not have one anterior dislocation, and I have never had one anterior dislocation through a posterior approach because of this technique. And he also described ways to test in all ways, in all directions, to make sure that we understand what the stability is and what it looks like when the stability is failing. This same thing is done through the anterior approach. You can see it's the same movement, testing the same issues, just in a different manner. The principles are the same. In the end, no matter how much we try to be perfect, stuff happens. And it's our goal in these meetings to figure out how to make stuff happen less, to minimize our variability. Regardless of approach, when we try to get too small, things happen. It diminishes our reproducibility. And I would challenge you, if the white box is all you see, can you know for sure that you're not perforating. These are the challenges in trying to minimize exposure. Regardless of approach, we need to understand what needs to be released and what are the criteria to release and how much should be released. Regardless of approach, releasing the gluteus medius tendon insertion is a bad idea, and understanding where that is in space is critical. Fundamentally, we all ask ourselves, can I be better? Can I be better at using a different approach, or can I be better using a better technique with the approach that I use today? We seek to diminish the variability of our execution, and there are many ways to achieve this. We also have to figure out what can we do to minimize the downsides of one approach over another. And here we can see proximal wound issues, which are related to obesity as demonstrated in this data, and can be mitigated somewhat with negative pressure dressings. And of course, there are some environments where it might be ill-advised to do an anterior approach here. We have to understand that each operation has a target and a margin for error. Each individual has a margin for error. And some approaches have a larger margin of error. If your shots tend to be towards the center of the bullseye, then you can tolerate a smaller margin of error. Everyone has to be honest about themselves, because there's an ethical quandary to change. There's a learning curve, and that learning curve for the surgeon equals a period of diminished quality for the patient, which must be mitigated by intense study. So the goal is so that regardless of which approach you're using, it looks and feels the same. Here is a cemented hip being put in through the posterior approach on top, through an anterior approach on the bottom. We're executing differently the same principles so that it feels the same, and so you have a great outcome regardless of which approach you use. And on that, we say, let's debate.
Thank you, Dr. Jose.
Perfect. So who's going to go first, Sahil?
We'll have Dr. Parvezi starting for the anterior approach.
Okay.
Thank you. Thank you very much, Jose. It's a true honor to be in the company of my great friends who are on this webinar. It's a great shame that we're not together in person. I miss being with you guys. I miss your friendship. It seems like we're stuck in a hell, but as Winston Churchill said, if you are in a hell, keep walking. And I think we will eventually get to the end of this as well. The human society is resilient. We will prevail. It's just a matter of time. So I hope we will have a chance to get together next year and celebrate again. It's an honor, though, to be able to debate Dr. Bendy, who I admire and I have been a good friend of. I honestly don't think there's a debate. I think Jose put this very beautifully, and that is preference for each surgeon may vary. Each one of us choose the surgical approach based on our preferences, our patient population, our surgical skills, and also our society and place where we practice. I will present to you today why I use direct anterior approach, and in the hope that you will understand that there is definitely room for direct anterior approach in orthopedic surgery and hip surgery. I am not trying to convince you to switch from an approach if you're comfortable with that, but I do think that you should consider some of the attributes of direct anterior. These are my disclosure, research support from various organizations. These are my personal conflict of interest. None of this is really pertinent. I have not been involved in the design of anything that relates to direct anterior approach. So I have no financial interest related to direct anterior approach. I think we will all agree that total hip replacement is one of the most successful surgical procedures. Next to cataract, is the most cost-effective surgical procedure that has transformed the lives of millions across the globe and continues to do so. regardless of how we do it. It's a successful, cost-effective operation with a very high survivorship. But errors happen, and unfortunately, mistakes occur. And that 98% survivorship is really not true because it overlooks the revisions, the readmissions, the reoperations that happen. And if you really look at the success of this operation in 1 year, is more like 87% rather than 98%. 4% of total hip replacement actually fail within the first 10 years as a result of infection. So if you just took infection as an endpoint, the survivorship at the end of 10 years is 96%. And then there are other complications: dislocation, limb neck discrepancy, impingement, loosening, periprosthetic fracture, etc., that all lead to a need for revision. So there is an increased need for doing a surgery that will become more successful. For us to think that we've come to the end of the line and there is no more innovation, I think that would be a mistake. And some of the errors and the problems that have occurred in the past is as a result of bad innovation. Look at the metal and metal story, the modular femoral stem, the thin polyethylene that fractured, etc. So these were some self-afflicted. And unfortunately, it did lead to the demise of many patients, the destruction of their soft tissues. So we have to avoid those. Any innovation needs to be properly evaluated. So are we there yet? Is total hip replacements reached its ultimate evolution? The answer is probably not. There have been advances in the field of every field of medicine as well as others. Remember the phones that we used to use to make telephone calls and not what we use. And we can in life belong to one of two camps. You can either belong to status quo, where you feel current situation is perfect, there's no need for innovation, or you could be the futuristic person when you strive to make things better and continue to innovate. But how do we get there? Novel technologies need proper evaluation. They need to improve on what we have. If you haven't read this Walter Isaacson book, I highly recommend you read this. It's Innovators. And if I were to paraphrase Walter Isaacson after reading this book, he thinks innovation has to fulfill three criteria. One, it has to improve on what we have. Two, it has to simplify life and make it better. And three, it has to make it affordable and more cost effective. Unfortunately, all innovations in medicine are introduced through these chaotic procedures. An innovator or a designer brings it into the market, gives a few talks, everybody else jumps on that bandwagon, and in the process, we end up hurting patients. This is what Henrik Malkow proposed back in 1999 in the Hip Society. There should be a proper evaluation, preclinical evaluation, some form of radiographic evaluation, randomized controlled studies, and then registries need to keep a close eye on what happens when that innovation is introduced. Data, you have to be careful. You can really torture the data to show what you want, and in the process, you could end up hurting patients. And not every data, unfortunately, bears into clinical practice. For example, the preclinical or some of these benchmark testings have not delivered on innovations. And here are examples of numerous innovations or so-called innovations that ended up hurting our patients. So we have to be careful, and we have to not fall victim to advertising and marketing. But physicians are innovators. See what we have done. This is how cholecystectomy used to be done when I was an intern in England. 14 days in hospital, intensive care unit, subcostal pain for the rest of their lives, numerous complications. When laparoscopic cholecystectomy came, there were a lot of skeptics, and there were a lot of complications in the beginning. But the surgical world continued to innovate, and eventually they prevailed. And now it has become the standard of care. Would you not rather see that happen in total joint arthroplasty? Let's take triple aneurysm as an example. Open laparotomy all the way from the subcostal region down to the pubis. Patients again would be in the intensive care unit, 24% mortality. And now it's done through endovascular techniques. So of course there have been innovations. I believe in total arthroplasty, there is room for innovation, and that does include the surgical approach. And when that innovation is effective, it will then translate to better pain control, better blood conservation, and of course, better outcome for the patients. My mentor, Dr. Rothman, was one of the ones who actually looked at the surgical approach. He trained with John Charnley. He came back. He used to do all his hips through the trochanteric osteotomy with the box wires, etc. So that he conducted a randomized prospective study. And what he found was that you could do the procedure without having to do greater trochanter osteotomy. And that was part of the movement across the orthopedic community towards the lateral approach to the hip. Sure, it improved on what we had at the time. It's very important to know that direct anterior approach is not the same as the two incision technique that was espoused as being one of the greatest innovations. And what we saw first was an interview of a surgeon in the ABC channel before we saw any data. Direct anterior approach utilizes the Hoyter interval or the Smith-Peterson between tensor fascia lata and sartorius, and then underneath the rectus is then retracted medially to gain access to the hip capsule. And there have been numerous publications that shows direct anterior approach is better in terms of early recovery. And many of them have also been randomized prospective studies. There have been 3 meta-analyses related to direct anterior approach. Cochrane database being one of them. 42 studies were evaluated, and they found that the mean functional scores were better for patients undergoing direct anterior approach in the first 6 weeks and better overall outcome. You might say, well, so what? In the first 6 weeks, they have better outcome. On Monday, I'll be operating on the chairman of one of our departments at Jefferson. His first question was, when can I return back to my activities? If I told him he had to wait 6 weeks, that's a big deal for many of our patients today. They want to return back to work and their function. They want to gain independence, and those 6 weeks are very critical time. Early recovery matters. Yes, it does. If the direct anterior and posterior equalize at 6 weeks, I don't really care. What I do care is that our patients do have a need for returning back to better function in the first 6 weeks. And other meta-analyses on 9 randomized controlled studies showing better pain, better functions, again, early time point, lower VAS, less blood loss, and overall better outcome. Why do I use direct anterior approach? Well, first of all, I'm a joint preservation surgeon. I do impingement surgery through the front. I do pelvic osteotomy through the front. And this is the same approach that I would be using for my joint preservation. Second, it's an easy setup. Patient is on their back. There is no need for shoulder bumps. There is no need for anesthesia to help us with the setup. You put the patient on their back. You then drape them. I don't drape both legs into the field. I only drape one leg unless I'm doing bilateral, obviously. And that usually allows me to also assess their limb length. I believe this leads to faster recovery. I've seen it in my patients. 80% of our fellows that leave our practice, they start to do direct anterior approach. And please remember that they get exposed to direct lateral approach and posterolateral approach. I think they're smart people that they see that there's a difference. And again, 4 out of 5 fellows that leave our practice utilize direct anterior approach as their preferred approach to total hip. If you're in a practice where all your patients are octogenarian, wheelchair dependent, very limited functional outcome, I don't believe switching to direct anterior approach is going to make much of a difference, because you will not see that difference in your patients. I did evaluate the direct anterior approach through a randomized prospective study in my own patients before I embraced it fully. And here's 200 patients. Half of them I did through direct anterior, half I did through direct lateral. Then we did very specific tests: time to get up and go, chair test, lower extremity functional recovery, return to driving, return to work, patient satisfaction, opioid consumption, etc. Huge amount of data. And what did I find? Patients who had their surgery done through DA approach did better than direct lateral. I know Dr. Bindi is going to try to convince us that posterolateral approach is different than direct lateral, and I completely agree. But there are also numerous randomized prospective studies, including one by our fearless moderator that shows direct anterior is better than posterolateral approach. So patients return back to their activities. This is a lady that comes and shows me at 6 weeks after her surgery how she does yoga. Sort of worrisome, but nonetheless, it happens. There are some fallacies related to direct anterior approach. The first one is that everybody will say, well, you need to have a specialized table. These are expensive to have. These are very difficult to keep. You need fluoroscopy during surgery. These may be for some of the surgeons. We don't. As I've shown you in the video, we utilize the regular operating table. We don't use fluoroscopy. We can restore limb lengths without needing to use fluoroscopy during surgery. But you do need specialized instrumentations, and double offset broach handle is one of the most critical ones. And it will be very, very difficult. I never forget operating in Madrid when I was doing live demonstration, and we were doing a right hip, and they had a double offset broach handle, but unfortunately it was for the left side. It makes you look incredibly bad, and it's very, very difficult to do this procedure without having the appropriate instrumentation. You do need to go through a learning curve, as Jose just mentioned, and I don't believe this is a surgical procedure for low volume surgeons. If a surgeon is not doing at least 150 hips a year, I don't believe they should be embracing direct anterior. And as Jose said, it's not for every patient either. There are those that have an issue in their groin, and the direct anterior should not be offered to those patients. Its wound-related complications can be higher, but I do utilize an occlusive dressing that stays on for 7 days, and that does minimize the wound-related problems. The second fallacy is that people say, well, if you get into trouble, you cannot do anything during direct anterior approach. Not true. This video is not playing, but it's a cadaver, but I'm showing to the fellows how you can make it extensile. If there's a fracture distal to the stem, you can definitely access the femoral canal, and you can certainly fix the fracture. I believe it's important to do this procedure on the regional, minimizes blood loss, it provides better relaxation of muscles, and makes your surgery better. This is a patient of mine 6 hours after surgery, very active. One of the Irish fellows took this video. I don't usually do these videos because I don't really believe they do much. But this is a 72-year-old lady who wanted to get back to activities. I didn't know what that activity was, but she was the first female boxing referee that actually was in there when Muhammad Ali was fighting Fraser. And I've seen numerous of her clips and videos on YouTube. What she wanted to do was to get back to a boxing match. She goes, this is her preoperative x-ray. She goes to this is her postoperative x-ray. You'll agree that this is fairly well executed. She goes to her boxing match, gets pushed and falls and sustains a periprosthetic fracture. So the other thing that you will hear from surgeons saying, oh, well, if you've done direct anterior approach, now you've got to fix this through a different approach. Not true. You can do this through direct anterior approach. You can definitely make it extensile, and you can try to fix with whatever instruments we have. That lady did well and came back to have the other side done. So surgical approach, again, brings with it a lot of other attributes, as I've mentioned. Direct anterior approach is a quick operation. I think Parag came and visited us. He will be able to tell you, usually we do these under 1 hour. There's low bleeding, less postoperative pain. Patients go home. 40% of my patients now go home on the same day. Shorter length of stay, shorter operative time. It does address a problem that exists. It is here to stay. It will be the most popular approach in the hip in the future. And if you don't believe me, look at this APAS survey. 5% in 2008, 5% of surgeons. And in 2019, that had gone up to 45%. Will it be the only surgical approach? No, by no means. It will balance, and it will be at the cost of direct lateral approach. In my opinion, we will come to a balance where about 45% are being done through posterolateral, maybe 50% are being done through direct anterior approach and only 5% through direct lateral. So the future is bright, and I do believe that direct anterior approach is a great innovation. And thank you to Jose for introducing me to it when I visited him many, many years ago. And thank you again for the opportunity to be on this webinar. I'll stop here.
Thank you, Dr. Parvezi. That was a fantastic talk. And you've really set the ball rolling. And I think Dr. Bhende now has an uphill task to match this talk, but I'm sure he's more than willing to match it. So I'll hand it over to Dr. Bhende to share his screen and start his talk for the posterior approach.
Good evening, everybody. It's evening in India. Good morning to Dr. Parvezi and Jose. We all respect Dr. Parvezi quite a lot because he has done a fabulous work on infection control, and his booklet on the work which he has done is like a Bible in India. So all orthopedic surgeons, if they have any issue about infection control, they refer to that Bible, and all issues are discussed with that as a reference. So let me apologize if I become a little offensive later on. But because we respect you so much, Dr. Parvezi, there are a lot of people looking up to you. And that's the reason I want to make sure that you don't preach them something which they won't be able to follow. Because I have been practicing in India for the last maybe 25, 30 years, from 1998 since I came here. But if you ask what is my experience in hip arthroplasty, we used to do all hip replacement by posterior approach in India. Almost 4 or 5 years, I was an associate professor in medical college. Then I went to England for 5 years. And in the next 5 years, I did not do a single posterior approach. In the various centers which I worked, I was doing either a direct lateral, anterolateral, Harding's approach, Liverpool approach. And in one center for exclusively 1 year, we were asked to do trans-trochanteric classical channel approach. So I was so comfortable with anterolateral or trans-trochanteric approach that I thought that's the best one. Then I went to USA. I spent 1 year with Dr. Ranawat. Jose was there. And that's time I realized exactly what is meant by posterior approach. And what a lot of people think what posterior approach is not what posterior approach actually is about. So approach to the hip joint is basically a way to do a good job recreating a normal hip anatomy. And we all have to realize that when we talk about approach, it is just a part of the whole scenario. So what is required for a successful hip replacement surgery? Well, we need to have good exposure to see what we are doing. Then we have to think about acetabular reaming, how much to ream, how wide to ream, what's the position of reamer, how to do acetabular cup trialing, final cup sitting, the version of a cup, inclination, depth, vertical position, etc. We ought to also take into consideration the effect of lumbosacral spine on the pelvic position, on the acetabular orientation. Think about dynamic position of pelvis of the and acetabulum while sitting and standing. And that's not it. We also have to think about femoral side, how to broach the femoral side, what size of broach, what depth of broach, the coronal sagittal positioning, what's the quality of bone, what's the final sitting of femoral component, am I going to use cemented, non-cemented, etc. Then you have to think about offset, neck length, limb length, restoration, tribological factors, type, size of articulation, restore the balance of soft tissues, do the soft tissue releases in a case of severe deformities, which we normally see in India, and then obviously close the hip joint. So if you summarize this, what is required for a successful hip replacement, it is all what you can see here on the screen. But if you listen to the previous talk, you may get a false idea that maybe you have got a good exposure and maybe a good closure. And if you can do it well, probably all the rest of the thing will automatically happen well, and you will get an excellent hip and a patient will be very happy. Now, if you get a complication, say like you get a dislocating hip replacement surgery. So what do? Normally, we should worry about all these factors which are there, the position of acetabulum, etc., etc. But from the talk, we feel that maybe if you do this exposure right, we will be not having any dislocation of hip at all. And that's the solution for it. My only suggestion is when we try to market a particular approach so much, and many times it is more of a marketing because people read on the internet about all the advertisements which come from the hospital, and they come and ask, do you do this approach, without realizing exactly what sort of hip damage they have and what kind of a hip condition and pathology they have. And that is many times puts the surgeon into a difficult position. And that's exactly what I do not want to happen to Indian surgeons. Now let us say, what is posterior approach? Now, when I went to United States for fellowship with Dr. Ranawat, Jose actually asked me to read this book, and that's why I read this book. And so probably one of the best books about hip surgery I've seen. And this was published in 1984, and it has presented 13 different posterior approaches described in that book called Tronzo. It started from 1874. The approach, posterior approach, is not a new one. Probably it's the oldest approach which is described for opening the hip joint. 1874, Langenbeck, improved by Cocker in 1887, changed by Gibson in 1947, till even 1957, Moore also presented a similar approach. Now, these are not same approaches. They are some variation of an approach to the hip from the posterior part. The Moore's approach became famous not because it was something great, but because Moore's prosthesis was probably the successful process to treat transcervical fracture neck femur at that point of time. And because the process became very famous, people started using that approach. But it was designed basically to use only a hemiarthroplasty, which has got a banana shape, a stem, which can easily be put into the medullary cavity, probably without cement. If you try to use a similar thing for a THR today, you'll create a lot of complication. So many times people do not realize that what we use today is not the Moore's approach. Beyond this book, in the last 20 years, there are at least 6 more different, in inverted commas, posterior approaches have been described. And so total, there could be maybe 18 or 19 variation of this so-called posterior approach described in the literature. So let us dwell a little bit upon what I mean by posterior approach. It's very important for people to know. Now, it can extend on one side like a Henry's extensile question mark approach, where you can actually expose the entire posterior part of pelvis, including the posterior wall of the acetabulum, entire sciatic nerve, the superior part of the pelvic, and it can be used for some massive surgery. On the other hand, Dr. James Cho has presented something called a super path. It's a intermuscular approach where you just split the muscle. It's apparently a percutaneous approach. I have not seen it, but from the description, you don't have to cut any muscle. You split between piriformis and gluteus minimus, go inside on the capsule. There are tubular retractor which can be used, and a special instrument which can be used to access the hip and remove the hip and put an artificial joint. And obviously you need to have a fluoroscopic or navigated surgery because you cannot get a good vision of the entire acetabulum or proximal end of femur. So the posterior approach can range in between these two big ends. So if you can look at this, there is the gluteus maximus muscle on the back, and Gibson approached it by a proximal incision. Cocker-Langenbeck did an incision which split the gluteus maximus upper 1/3, lower 3/4, and Moore's approach was quite inferior. And if you can see, this approach actually is going across the sciatic passage, and that can cause sciatic nerve injury if you try to use Moore's description of this approach and try to do a THR in your practice. So what is actually better is what was described by Tronzo, and he used a bang lateral incision. And we have a variation of this Tronzo approach as what I learned from Dr. Ranawat. Now, this is what we normally do. We have an incision starting from the tip of the trochanter, going backward by about 40 degrees, splitting the upper part of the gluteus maximus and going distally by about 3 to 4 finger breadth along the length of the femur. And when we make the incision, we split the gluteus maximus and a tensor fascia lata. We can go on a trochanter and you can see the gluteus maximus. Now, gluteus maximus is a fan-shaped muscle, and it is very important to preserve the muscle because the entire stability of the hip depends on the integrity of gluteus medius. And Jose has mentioned in his introduction, anything which damages gluteus medius is not good for the hip joint. So what is done in a posterior approach? You go behind, posterior to the gluteus maximus, gluteus medius wall, and we expose the plane over there. So if you can see, there is a piriformis muscle, and between piriformis and minimus, we open the space, and we open the space up to the piriformis fossa and come along the posterior wall of the trochanter. And entire thing, all these rotators can be lifted off the bone as a single structure from the muscles and the capsules all together. Now, it is very essential not to cut the muscle in the tendon, because then it is difficult to suture them back. When you keep muscle and capsule together and develop a single flap, it is much stronger and it's much easier to suture it back, because the suturing it back is an important part of any posterior approach which you use. Now, many times, if you don't get good exposure, you can always extend it down to release your gluteus maximus tendon, or you can even go further down depending on how much distal you want to go. You can even go on a shaft in a case of revision cases. It doesn't mean that every time you do all this, every time you open everything as you see on this picture, you have to open as minimum as you can. And that's why some of the people believe that even piriformis is something which they want to preserve, and the incision can be done below the piriformis, trying to preserve the piriformis. Although I don't believe that it can be preserved if you want to go and enter the medullary cavity of the femur through the piriformis fossa, because that reaming act sometimes can disengage the piriformis tendon from its bony insertion. But that's the one description where you try to preserve the piriformis to improve the post-op stability. There are other group, we want to preserve the quadratus femoris muscle, and their incision is more proximal, preserving the entire quadratus femoris muscle attachment to the back of the trochanter. So if you can see, there are multiple muscles and multiple ways to open the hip. You do not have to open everything. You can start with a bigger opening, and as your experience grows, as you become more mature in your practice, and if the case is relatively simple case without significant deformity, you can really make a small incision and do the surgery without significant soft tissue damage. And once you restore that capsule back with the osseous sutures, then usually you can get a very good stability. The hip is dislocated easily by internal rotation, as you all know. And if you want to have any difficult hip, many times you may have got a significant tightness of the anterior capsule. And in these cases, you can actually rotate the hip externally, abduct it, go in front of the trochanter, in front of your gluteus medius, and expose the capsule, as you can see over there. And this is also what I learned in Lennoxville with Dr. Ranawat, because it allows you to actually approach the hip from both the aspects, front and the back. And obviously, it is not done for all the cases. You may have to do this maybe 10 in 100 cases. But most of the time, you know that if there is a problem in balancing the hip, I can easily go in the front and balance my front and back very well. Important point to remember here is we must suture back the capsule which is released from the greater trochanter to the trochanteric bone by osseous sutures. And this is probably the single most part to remember if somebody wants to go for a posterior approach, whether it is a small section taken from only the rotators keeping the quadratus femoris intact, or where you preserve the piriformis. It really doesn't matter as far as you bring all those capsular and the muscular structures back to the trochanter. So what is a posterior approach? Again, let me recapitulate. It is a plethora of multiple approaches. It's like a big big list from which you can select. So you can extend as much as you want, or you can go as small as you can afford to go in a particular case. And that is the reason when you go by this approach, you do not have to expose everything else, everything in every case. Now, what can we do with a posterior approach? In India, many times we get difficult patients. Very rarely patients come with a mild primary or osteoarthritic hip joint. So you may get patient like this, which has got a severe CDH, female, multiple surgeries done, and you may require a surgery which will have reconstruction of acetabulum and a femur. You may get a patient who has been treated in the past by abduction osteotomy and excision hip, and come to you after 10, 15 years, and you may end up doing surgery like this, where you may need to do a subtrochanteric osteotomy and reconstruction of acetabulum by putting a graft. All those things are possible by posterior approach. If you try to go by direct anterior, obviously these are not the cases you can do with them. Another case, severe badly damaged femur, multiple fractures, and this can be treated by cemented THR like this. Post-burn myositis, again treated bilateral THR done, patient is doing very well. Excision hip, post-traumatic condition, THR done. Again, a bilateral dislocation hip with burns and myositis. Again, you can go ahead and do good hip replacement surgery and get a functional capacity back to the patient. So, as I mentioned, primary osteoarthritis of the hip as a diagnosis for THR in India is only 11%. 90% people come to us with a diagnosis other than primary OA where the hip is damaged. It is more often either ankylosing or a post-traumatic condition, a post-surgery condition, rheumatoid arthritis, or a severely bad damaged avian cases. So all these cases, doing a direct entry approach, although it looks very neat and cute, it may not be very easy. So when I have a super flexible approach in my hand, question is, should I try to learn an approach which is 1, limited in extent, 2, difficult to perform, 3, excessive stretching of the skin can cause skin damage, almost 10 to 20% cases. Risk of intraoperative fractures are there in almost 7 to 23% cases, and there is a high risk of injury to the lateral cutaneous nerve of thigh as per the many publication which is there in the literature. So if I still have to learn, it will mean I take a small incision, I do excessive retraction of a skin, that may cause skin damage, it may cause bone fracture, but I have to reassure the patient not to worry about it. I may have poor visualization, so I have risk of malpositioning my components. So automatically I have to use the fluoroscopy, maybe navigation. That means I'm exposing myself and my surgical team and a patient to radiation, and obviously higher the cost. It is increased time for surgery. And at the end of that, I do take pride in saying my patient has gone home 24 hours earlier than probably a small posterior approach. What is the cost for learning this new approach? And this is a very good paper which I found, where this is a high volume surgeon who has presented 800 consecutive cases of his practice done by direct entry approach over first 5 years. And he's a high volume because he's doing more than 200 plus cases of hip replacement every year. So we can apply his statistics to all the people in India who want to learn these things. He has analyzed them and analyzed how the complication occur chronologically. If you can see, most of the trochanteric fracture, the femoral perforation, femoral fractures happened in the first 200 cases. After 250 cases, the risk of fracture was significantly reduced. But that means first 200, you are going to get a lot of patients with a trochanteric fracture. Then wound healing problem was there throughout the 800 cases. Even at 200, 400, 600, the incidence of wound healing complication was same. That means this is something, the excessive stretching, you probably cannot avoid. And this is going to be there all the time. What about dislocation? Now, we thought that there may not be any dislocation, but he has reported 1% rate of dislocation in this approach. And most of the posterior approach, if you can do a good posterior repair and good alignment of orientation of femoral component and acetabulum, the risk of dislocation can be as low as 1 to 1.5%. What about thrombosis and embolism? Although it is supposed to be a small, minimally invasive approach, they still have a significant number of deep vein thrombosis and pulmonary embolism. So he has shown that in his learning curve of 800 cases over 5 years, there are enough number of complications that makes me fear to start these operations and try to learn it. Larry Dorr has mentioned, if one has a problem with the cases he is doing, instead of blaming it on the approach, one should find the causes for the problem. Because just changing the approach will mean changing one set of problem with an entirely different set of similar but unfamiliar problems. So changing the approach from posterior to anterior, you may not still solve the problem of dislocation, or you may not still solve the problem of malalignment or orientation. Let me give an example. This is a picture of notes written by my physician. And when he writes a note, nobody can read. And the sister is significantly worried about what he has written. whether he has given a fitness for a patient or he has not said patient is unfit for the surgery, we have to really struggle and call him back. And my fellow also is no good because sometimes he writes prescription like this. Unless we have a printed one, handwritten become like this. I always wonder why they can't write like this, a nice, good handwriting. It's so simple. We are learning it from the childhood. And I was thinking about what to do. And my daughter showed me one, film. And just watch the film, how this man is elegantly holding the pen in his hand. He removes open the pen and hold the paper and start writing with his foot. And he writes few letters and look how well he writes. Look at his handwriting. Look how clear it is. And just compare that in your mind with what my physician or my fellow was writing with their own hand on the paper, which is an important medical legal document. Looking at this film, I was really impressed. I thought I got a solution for bad handwriting. We should start learning with our feet to write. And then the question came to my humble mind is, should I ask my physician to change the approach to his writing? Should he learn something new approach of writing? And should I ask my fellow who is still young to learn this new approach so that in his armamentarium of writing, there will be another approach probably with which he can do a better job of writing. I'm thinking about it. Thank you very much.
Thank you, Dr. Bhinde. That was quite a solid reply. And before we have the expert comments from Dr. Jose Rodriguez, we'll have the rebuttal first. So a 3 to 5 minutes rebuttal from Dr. Parvezi.
Yes, thank you so much, Dr. Bendy. Beautiful presentation as always. Enjoyed it very much. I think after listening to your talk, you and I are more on the same page than we are different. We are on the same page on numerous accounts. Number one is that direct anterior approach is definitely not for low volume surgeons. And in India, because you don't really see that many hips, and the hips you see are incredibly complicated cases, I think less and less of these cases would be or could be done through direct anterior approach. For sure, I agree with that comment. The second is that if you're a good surgeon and you have mastered one surgical option that works for you, both for primary and for revision, you should most likely stick to that surgical procedure and not have to learn all of them and try to master them all separately. And then finally, yeah, I loved your innovation in terms of changing some of the ways we approach medicine and orthopedics altogether. And this COVID problem has actually shown how inefficient medical practice is and how we have great opportunities with use of telehealth and digital health really revolutionize patient care in the future. And I'm hoping that with India being the master in IT world, you will guide us in some of these ways to try to improve our patient care and make their outcome better. So all in all, as always, I enjoyed your words of wisdom, and thank you very much for your kind words. And I look forward to, again, seeing you all in person. Thank you.
Thank you.
Yeah.
Yes,
Thank
Dr. Bhinde, please.
Thank you, Dr. Parvezi. Well, I entirely agree that the direct entry approach is very elegant approach. It looks very nice and wonderful. And probably a certain set of people, certain number of patients, it would work wonders compared to the posterior. Maybe at the end of 6 months, it may not matter too much, but in the first experience of first 6 to 8 weeks would be better with direct entry approach. There is no question about that. The only problem is because it is so much in a news, I can say, I cannot say it is being marketed, but it is so much in a news that many times in India, people come to us very well equipped with all the data from Google and internet. And the first question is, doctor, do you do it? Without realizing what sort of hips they have. And well, maybe a senior surgeon can tell them, look, this is not what is meant for you. But many times junior surgeons have seen trying to comply with their wish because they always fear that, well, if I say no, this guy will not stick to me. He may go to somebody else. And then they are pushed to do this approach without realizing or without having good experience. So I really wish that there should be some centers which are doing this in a big number in India, where they select those patients which are eligible to be done by direct entry approach, and young surgeon can easily learn that. There is nothing wrong with it. But as I said, I myself haven't done it. Whatever I've seen, couple of demonstrations we had seen last year in one of our national meeting was a disaster on table. And that must have put off many people trying to go for it. But it is an elegant approach. There is no question about it.
Okay, I have some questions. We'll keep it short because our time is late. My question to Harish, do you believe that the common understanding of the principles of posterior surgery are now well evolved? Do you think that we have arrived, we understand the posterior approach as well as we can? Not you, but everyone, common understanding.
Most of the people know how to do it, but as I was mentioning in my talk, posterior approach is not one approach. It's a amalgamation of at least 20 different approaches with 20 different structures through which some of them you preserve, some of them you don't in certain approach. And what is the safest one is not what is understood by many people.
So your answer is mostly?
Mostly, yes.
Jay, do you think, same question, do you think that the common understanding of the principles of anterior approach are now well understood?
Mostly.
Okay, I disagree. I think that the posterior approach is well evolved. The anterior approach, many people, even people that are teaching it, don't really understand the anatomy very well. And this is just part of what's going to happen with time. We, the overwhelming we, are still learning. And to that extent, I understand Harish's frustration. Next question. Harish, what is your most common challenge in teaching? What's the hardest thing for a trainee to learn?
In THR, teaching the hip replacement surgery, the most difficult part is to teach them how to do soft tissue balancing at the end of the surgery. Because it is not described much in a book like a balancing of a knee, where you know various ways of balancing medial, lateral, etc., etc. But hip also need to be balanced. And that need to be balanced by doing certain maneuvers when you do trial hip. And those things has to be understood well by a surgeon, whether they go by anterior approach or a posterior approach is immaterial. Agreed. And that Jay, is most difficult.
Same question. What's hardest for the trainee to understand?
Yeah, so small incision through direct anterior approach. Visualization is poor, as you have said earlier. And I think in the process of trying to expose the femur and even acetabulum, they are very disrespectful to the soft tissues. And it's terrible to see the TFL get shredded, to see parts of even short rotator get involved, etc. And I think soft tissue handling it through direct anterior approach is really the major issue. I know people talk about the femoral exposure is very difficult, but that's all part of the soft tissue respect that I think they don't learn. Another pet peeve I have is I hate residents and fellows to put their fingers in the wound. And unfortunately, it looks like, they're always putting, the fingers are always in the wound, which really is not a good thing to do.
Indeed. Well, I would love, because I like you guys so much, to keep talking, but I think that we have a panel that needs to get together.
Yes, Sahil. So any questions from your side, Dr. Joshi?
Yeah, so my first question would be to Dr. Rodriguez and Dr. Parvezi. You said this is not a surgery or not an approach for low volume surgeons and at least 150 cases a year. So what is the learning curve that you would see a new fellow or a new trainee who wants to adopt this approach? How many number of cases would you say encompasses the learning curve?
Go ahead, Jay.
Great question, Sile. I said 50 in my slides, but remember there are two ways to become a direct anterior surgeon. One is you are a fellow of Dr. Rodriguez or at Rothman, where you get exposed to it, you get methodical training throughout the year, you see the intricacies of the procedure. You may or may not have done 50 at the end of the year, but you become very proficient by the time you're done. The other is as a senior surgeon or even as a junior surgeon, you've never had that methodical and proper training. And then suddenly one night you decide you're going to start doing direct anterior approach. And that, in my opinion, is a much, much steeper learning curve, and you may never overcome the issue. So I hope Jose will agree, but I strongly feel that surgeons should not be taking this approach in the middle of their practice unless they do multiple cadaver sessions. They go and train by people like Dr. Rodriguez, spend time with these surgeons, then perhaps have those surgeons come to their first or second cases, and then if they have the volume, they will be able to overcome that volume.
There's nothing I can add to that.
So about 50 cases. Okay.
To me, when I started, and my training was not good, although I tried, it took me somewhere between 200 and 300 to feel, okay, I got this.
Mm-hmm. Okay.
That's a big number.
Yeah,
but again,
can I just interrupt? If you see that paper which I mentioned, that guy has mentioned 200 cases after which the incidence of fractures start dropping down, and it was almost zero beyond 300 cases. The trochanteric and other fractures. And he had done 800 cases. Yeah.
That doesn't have to be the case now.
No, I know.
If you go to Rothman, you don't have to go through that learning curve. And that's the thing.
That's correct.
You have to really focus intensely on avoiding these problems.
And the second part of that question is, what are the most common complications you encounter in that learning curve?
My learning curve, again, not well mentored. I had a couple of early periprosthetic fractures of first, the trochanteric fractures. That happened in my first 50, and ever since then, I've not had a trochanteric fracture. That's a true learning curve issue. Mm-hmm. Learning how to broach to not get an early B2 periprosthetic fracture, that took time. But it's absolutely learnable. And now at HSS, we did a recent review of about 3,000 cases. There was no difference in the early periprosthetic fracture rate anterior to posterior.
Mm-hmm.
I agree.
Would you like to add to that?
I agree completely. I'll add one more, and that's soft tissue. Again, wound-related complications are a little higher during the learning curve because you sort of don't know how to move the incision up and down. You don't want to put it in that groin crease. So I completely agree. Those are the learning curves.
Longer. Make the incision longer, regardless of approach.
Exactly. Make it longer. Yes, that's true.
Yeah, so I have one comment and one question, Sahil.
Yes.
So I've actually seen Jay operate his direct anterior approach. I was there for the infection meeting, and then I was a little early, so Jay invited me to his OR, and I saw him do it. In 20 minutes, he was done. We went for rounds to the floor, and that evening, that lady was sitting, and the next day she went home, and she walked in front of us. So I've seen it. So the advantage of early mobilization is definitely there with the direct anterior approach. But my question to Jay is, how much important is early mobilization and that confidence of the patient who really feels so nice, hardly any pain, walking, going home the next day, versus the posterior approach, which takes a little longer to heal and is definitely a little bit more morbid. So compared to that, but at the end of 3 months or end of 8 weeks, they probably do the same. So in your mind, Jay, what is the advantage of early mobilization and getting back on your feet early? Does that really increase the confidence, or what are your thoughts on that?
Sure. Thank you. A very important question, Parag. So early mobilization is not just a surgical approach. In my opinion, it's dependent on your pain management protocol, the anesthesia, what type of anesthetics they had, the amount of blood loss. And as you notice, we're really, really careful about blood loss. You know, I hate seeing bleeding vessels. We give tranexamic acid. And then on top of that is the patient expectations and their functional status beforehand. As I said earlier, if your patients are all octogenarians, deconditioned, very, very sick, honestly, I don't think if you did their hip through direct anterior approach, they're going to walk early, and I don't think they're going to go home early. In fact, you will not notice the difference in the surgical approach. But there are those patients that want to go home early, and they do have other things that they want to do. For example, I just gave you the example of this chairman of the radiation oncology coming to have a surgery on Monday with me, and he's asked me when can he go back to his meetings and attend departmental meetings, go back to meet with his faculty, etc. For him, 3 days is a long time, and he's going to notice that difference. And in that patient, I think direct anterior approach will make a difference. Now, one big confession I have to make is I have never done a hip through posterolateral approach, and I have no idea how their recovery is. But if I were to guess, I would say that the posterolateral approach is so much better than direct lateral approach that we used to do. And I agree with Jose. Taking down gluteus medius is probably one of the biggest crimes you could make during total hip arthroplasty. So to answer your question in a long-winded way, Parag, I think it's a combination of everything, and I'm not that simplistic to suggest that just because I did their hips through the front, they did so much better. I think it's just all of the protocols that we put together that really made that difference too.
Perfect. Thanks, Jay.
I have one question to ask. And the question is, what is the minimum range of movement you would want in a patient to have before you can think of doing a direct anterior approach? And how much abduction, adduction, range of movement and rotation, you would say that this would be a good thing to start doing a anterior approach. Because if you have a fixed hip, or if you have a hip which has got a contracture in say in either external or internal rotation, and then you really start going one direct anterior approach, will that be easy or will it be more difficult?
Learning curve should include mostly simple patients. And as you get knowledge and confidence, then you can start expanding. I do hip fusions to the front. I can do anything to the front, basically. The question is, after a certain point, when you start releasing the reflected head, releasing this, releasing that, is there now a benefit to going through the front, right? The whole concept is tissue preservation. I can do a full revision, osteotomy, anything to the front, but after a point, the tissue preservation is not there. So there's no benefit anymore. Mm-hmm. So when you start learning curve, easy cases, period.
Completely agree.
Okay. So another big factor, especially in our patients in this part of the world, is with regards to post-operative restrictions after total hip arthroplasty. And especially most of our patients, because of lifestyle reasons or religious reasons, they have to sit cross-legged, sit on the floor, squat. So with the anterior or posterior approach, are there any post-operative restrictions that you would allow with one and not with the other? And what are they? Dr. Bhinde, would you like to start with the posterior approach?
After posterior approach, because we have repaired the posterior structures by the osseous sutures to the bone, we want them not to stress it too much. We allow them unrestricted movement, standing, walking, stair climbing, etc. But we don't want them to sit on a floor. No, not for the first at least 2 to 3 months. Beyond that, many of them sit regardless whether we tell them to sit or not. And many times they come and tell me, see, doc, I'm doing this. Why did you say no to me? And believe me, it is not the approach which matter much in terms of dislocation. It's the orientation of your acetabulum and the orientation of your femoral head and their orientation with respect to the pelvis. So you have to think about the standing and sitting position of pelvis, the dynamic orientation with respect to the how the spine is working on your pelvic bone. So if everything is put together right, usually many of them can sit on the floor, especially if you have got a large ball like 32mm head, that usually wouldn't matter much. But I think it's the orientation of cup and a stem and the soft tissue balancing, which is more important than the actual approach, what you do.
So,
but I protect this approach for 6 weeks because I think that's the time required for the osseous tissues to heal.
So after 6 weeks, would you allow all your patients to sit cross-legged and squat? Or no?
Cross-legged, I have no issues. They can easily sit because we are doing external rotation and abduction. That's a stable position for a posterior approach. They is not going to dislocate in cross-legged position. Squatting on the floor, like in an Indian toilet, it's a bad thing because you are flexing so much that you are, and especially if it is an obese patient, the fat on the medial part of the thigh will just have a camming effect on the ball to push it out of the acetabulum. So you have to be careful there.
With the anterior approach, Dr. Parvezi, any comments?
Yeah, the restrictions we have, it's not to do with the worry about dislocation. It's to do with the worry about rotation or torque on the femoral component that could end up leading to aseptic loosening. So usually I ask these patients not to do extensive high impact exercises for 6 weeks, especially because the majority of these patients are young and they really want to get back to their activities. After that, I let them do anything. I even let them run marathons. So they can sleep on their side. They don't need a pillow. They can use the regular bathroom, etc. No, dislocation is not an issue. The issue is if they are not too careful, they could shift the components, in particular the femoral component.
Dr. Rodriguez, any comments?
Nothing to add.
Okay.
I have 2 questions. What is the choice of the bearing you would have? Would you take a ceramic on poly most of the cases or ceramic on ceramic? And the other question is, in majority of the cases I have done, I don't find that all the acetabula are the same. Like you have a huge range which goes from retroversion to anteversion. And similarly also for the neck of the femur, the anteversions are different. But we land up putting all of them in more or less a very similar type of anteversion, both in the cup, inclination more or less 40 to 45. And in doing this, are we changing the dynamics of the hip in people who have primarily a retroverted hip? What would you say to that?
Dr. Bhinde?
Yeah, see, acetabular orientation, we normally put flush with the rim of the native acetabulum, unless it is significantly retroverted or significantly anteverted, in which case I need to get a CT scan of a pelvis to see how it looks on the opposite side. Then I need to take a standing X-ray of a pelvis in a lateral view to make sure that the pelvis is not tilting too much front or back. And all that then make me decide exactly how much version correction I need to do vis-a-vis the patient's native version. But if a patient has, say, for example, a normal patient pelvic anatomy and a patient is a case of avian, so it's just a ball which is gone and damaged. So I would put my cup flush with the periphery of the native cup, and the version of the neck will be whatever the patient's version has, because you get reasonable idea about the version by the neck. The logic is the patient is used, the muscles of the patients, the origin on the pelvis and insertion on the femur are used to work in a certain orientation. And if you keep the cup and a ball in the same orientation of version, they will work better. If you change it artificially in too much excessive anteversion, which is the commonest error surgeon does when they do go by a posterior approach, because they are worried about posterior dislocation, they antevert it too much. Hip will dislocate in the front. So it's not so difficult if the native acetabulum is normal, but if it is a dysplastic acetabulum or is a post-traumatic case, acetabular fracture, then I would like to have a scan and then standing X-ray, and then I make up my mind of exactly what version and inclination to be given to the cup.
Dr. Parvezi?
I totally agree. And I think there's, Dr. Joshi, we make some adjustments during the surgery. You know, dysplastics are the most critical ones. They have such an excessive anteversion on the femur that makes the acetabular component position very critical if you were to try to avoid instability. So I do individualize it in each patient. And the anterior rim of the acetabulum is very critical. But in these retroverted sockets, sometimes if you relied on that, they would end up being retroverted. So you do need to actually trim down the anterior wall in some of these cases and deepen the socket. The other element that's very important in these patients is the center of rotation of the femoral head. And you have to be aware of it. Some people have excessive valgus, some people have excessive varus on the femoral neck. Females usually have valgus. And if you put them in varus and you push their hips out, one, they're very unhappy when they stand in front of the mirror. Secondly, they develop abductor bursitis or abductor-related pain for the rest of their lives. So I look at the x-rays, I try to reproduce their anatomy as closely as I can in every single case.
Dr. Rodriguez?
I agree mostly with the last thing that Jay said, that you really want to restore where they were. I'll always put, as Hadi said, always put the cup at the anterior wall, the true anterior wall. My anterior approach sockets are generally smaller because if you impinge on the back with an overhanging rim, you're more likely to sublux anteriorly. So if you have a smaller cup, it can go more. Having more cup sticking out posteriorly in a posterior approach is useful because that's where you come out. You get more coverage, right? With an anterior approach, it's negative because it's an impingement point. So that's the only difference. I always put the femur where the femur was, unless it's a dysplastic with very bad antitorsion, and that patient has been constantly forcing themselves to insulin rotate just to walk normally, and they really appreciate having that change when you ask them.
Right. Okay. So I think we can go on and on probably with this discussion, but because of some time restrictions, we'll bring the meeting to an end. Thank you very much, gentlemen, that was a fantastic webinar. We have a lot of take-home messages, and I'm sure our viewers must have benefited a lot from your pearls of wisdom. And any closing comments from our moderator?
I would request, each one, Jay Parvezi first to give a comment, then Harish Bhende, and then Jose will end it. So just last 3 minutes.
Thank you so much. I've said all I wanted to say today. What I want to tell you is that we are really fortunate to be practicing a surgical discipline that provides incredible relief of pain and improves function for our patients, regardless of what surgical approach we use. We are just also privileged to be in the company of friends and intelligent men and women in our profession that makes the practice of orthopedics so rewarding. Thank you so much for being friends, and I look forward to shaking each one of your hands and having a glass of wine with you. Thank you.
Harish?
Just to end, I would like to remind all my Indian viewers, last time when I saw Jose, he had a lot of hair on his head, and I heard he was using posterior approach. And recently I heard he's using anterior approaches filled with a lot of stress. Yeah. I have stuck to posterior approach, so you can see this, So you decide what you want to do, and everybody, what works for best for them, they should do it.
Well said. Well said. Jose, I hope his comments are not true. Over to Jose to conclude.
I conclude that beautiful surgery is beautiful, no matter how it's done. It's just lovely to behold. And it's such an honor to be in this quest towards improvement of ourselves and our patients with all of you gentlemen and ladies in the audience. Thank you.
Thank you. Thank you, everybody.
Thank you, everybody.
Thank you. Thank you so much. So I think we can stop going live now.
And thank you, Ashok. Ashok is our coordinator who runs the meeting, and he's the one who started OrthoTV, Jay Parvezi and Jose. So thanks, Ashok.
Thank you.
It was lovely.
Thank you, Ashok.